So it's my pleasure to introduce my colleague, Dr. Stephanie Cizek. If you haven't gotten to know her yet, this Grand Rounds will serve as an introduction to her knowledge and competence and compassion. She's really a delight to work with, and I'm so thrilled that she chose to join us here at Stanford after completing her fellowship in pediatric and adolescent gynecology at Cincinnati Children's, which is a lovely connection because that's where I came to Stanford from. Stephanie attended Boston College. She majored in biology with a minor in chemistry. She did her med school training at Case Western Reserve in Cleveland, and she did her residency at Kaiser San Francisco prior to her fellowship. I really love looking at people's CVs because I learn things about them that don't come up in everyday conversation. I was reminded that Stephanie spent 2 years teaching sixth grade science in Washington, D.C., and that's really consistent with the patients that I see that she gives to her pediatric patients. She worked as a research assistant in Boston. Today, she's going to talk about DSDs, the term that itself is controversial. The term was described in 2006 in a paper that was a combination, came out from the US Pediatric Endocrine and the European Pediatric Endocrine Societies as disorders of sex development. The term has been controversial. The previous term of intersex is one that is actually preferred by some individuals in this group. Other terms that have been used are differences of sex development or divergence of sex development. So I personally prefer differences, but we'll hear what Stephanie has to say. And we'll also hear, I suspect, that the controversy about the name is not the only controversial issue in this particular subject and topic. In 2007, when I came to Stanford, there was an interdisciplinary group that included pediatric endocrine and urology and ethics and patient representatives, neonatology, psychiatry, a really lovely group that addressed the issues of DSDs for a while. But ultimately, the logistics of the group got complicated and the group stopped meeting. And when Stephanie came to Stanford, she realized the need for such a group and for the sake of patients and parents, and is in the process of putting this group back together to look at DSDs. I look forward to hearing what Stephanie has to say, and good morning, Dr. Cizek.
Thank you, Paula. I'm going to share my screen right now. Let's see. 1 second. Oh, wait, I have to put it on. And then if I share, are you seeing the full screen right now, or are you seeing my presenter view?
I'm seeing presenter view.
Oh, let me try again. Okay, now do you see the full screen?
Yes.
Okay, perfect. All right, so I'm Stephanie Cizek, as Paula said. I joined the faculty here last October 2019 after completing a fellowship at Cincinnati Children's. I was really lucky to work there, and that was my first introduction to patients with differences of sex development, as they have a really robust clinic there for DSD conditions. And that's actually one of the reasons that I came here to Stanford, is I knew that Packard had recently reestablished its DSD clinic, and I really love working with those patients, and I would say it's actually one of my favorite parts of my job. I'm also so impressed with my colleagues who are the other members of the DSD team, which includes people from our own REI division. And we'll talk more about all the different specialties that are in it. but I think some of them are actually on the Zoom presentation today. So thank you guys for joining and watching. I have no interest to disclose. My focus for this lecture will be on the current controversies and new perspectives in the field of DSD, and that's going to be a running theme throughout our talk, connecting that to patient care in the current social and political climate. As I do that, I want to incorporate 3 sub-objectives, which are 1, to ensure that everybody understands what DSD conditions are and how they're currently organized. 2, to understand how our multidisciplinary DSD team here functions to address complex care issues which involve the patients with DSD. And 3, to understand how to utilize our resources and refer to our DSD team. So let's start by talking about what DSD conditions really are. Oh my gosh, embryology, don't panic. Really, to understand the complexities, we really need to step back for 2 minutes just to talk about embryology very quickly. It helps to make more sense of the diagnoses and the exam findings. So sex determination is the process by which it's decided what gonads will live inside of you, and which in turn decides what hormones you will produce. What gonads live inside of you is decided by a complex interplay of gene expression. There's at least one gene on here that most of you have heard of, which is SRY, or sex determining region on Y, which cranks up expression of SOX9, which in turn causes the testes to form. Then the Sertoli cells in the testes make AMH, which causes Müllerian ducts to degenerate. AMH in girls at birth is undetectable or very low. So if you have higher levels of AMH, you automatically know that there is likely some testicular tissue present. During the process of sex development, you have at some point a bipotential gonad with both a Wolffian duct and a Müllerian duct present. AMH expression again causes the Müllerian ducts to degenerate, and testosterone causes the male structures to form. And then, of course, down here, the lower portion of the vagina is formed separately. The urogenital sinus separates to form the urethra and the lower 2/3 of the vagina with the hymen. The urogenital sinus is also crucial in forming the external genitalia. I want to show you this diagram just very briefly because I'll be mentioning urogenital sinus a few times in this lecture, and I want you to see schematically what that looks like. So if you look at picture C here, this is a part in development where you still have a common channel or a cloaca. That's the urinary, reproductive, and anorectal tracts together. And actually, I work separately with the colorectal and urology team to take care of patients with persistent cloaca. But persistent urogenital sinus is part D, picture D here, is where the rectum has already separated, and remaining you have this urogenital sinus, which is the common channel for the urinary and reproductive tracts. And a persistent urogenital sinus is a common exam finding in DSD conditions. The external genitalia by week 12 of gestation are already recognizably female. The distal urogenital sinus becomes the vulvar vestibule, and the nearby genital swellings form the rest of the vulva. And on the right side, you see that under the influence of testosterone and the even more potent androgen DHT, you get the typical male external genitalia. And that's all for embryology, I promise. So when any of these processes go awry, you can end up with a DSD condition. A difference of sex development is a congenital condition within which the development of chromosomal, gonadal, or anatomic sex is atypical. As Paula said, the term DSD actually was put into common use with the 2006 consensus guidelines and initially stood for disorder of sex development. It was meant to replace terms like intersex, which some people feel is pejorative, but actually many patients now identify with. Also to replace terms like hermaphrodism, pseudohermaphrodism, or reverse sex, which were still in common use. DSD is felt overall by patients and their families to be better, but not everybody feels included or identifies this, which has real consequences. There's consequences for the patients, including some patients who choose not to attend clinics called DSD clinics or to participate in any research that's labeled DSD. It also has consequences when you're trying to determine the incidence and group conditions together. For example, many estimates of DSD conditions put it at around 1 in 4,500 to 1 in 5,500 births. But if you include all reproductive tract anomalies, such as anorectal malformations or hypospadias, suddenly it's much more common. And if you look at subgroups of conditions like 46XX DSDs, these are mostly made up of people with congenital adrenal hyperplasia, but many people with CAH now don't consider themselves to have a DSD condition. The classification system from 2006 was also trying to make it so that we're all using the same terminology. For example, older terms like pure gonadal dysgenesis or names that are eponymous are not helpful and make it very difficult to compare cases and research, which for rare conditions is already a challenge. There are 3 buckets of DSD based on karyotype, and then these are further subdivided into disorders of gonadal development in the first boxes, and then disorders of androgen synthesis or androgen action for XY individuals, or excess androgen for XX individuals. Who do we see in DSD? Really anyone who fits in any of these conditions if we feel that they might benefit from seeing multiple specialties. We see obviously a lot of the more classic DSD conditions, but some of this is changing. For example, MRKH is considered largely just a structural anomaly and often is seen by gynecology by themselves, but we now have a lot more genetic testing that we can offer these patients, and the vast majority will need psychologic support, preferably from somebody who has done this before. So we're seeing more and more people with MRKH who prefer to be seen in the DSD clinic. Rates of people identifying as transgender do vary by DSD condition, and there is thought to be some biologic basis to this, but transgender identification is not a pathology and is not included in DSD. So part of what I really love about DSD is that every one of these things is taught to us to some degree, and to some degree societally ingrained in us, that each of these is a binary state and that they all have to line up all male or all female, but they're none of them binary states, and they do not have to all line up. And it's really not easy for patients and families, for medical providers, or certainly for politicians to grasp that your karyotype does not define what the sex of your gonads and the sex of your genitals are, and your sex does not define your gender. For us in the DSD clinic and with the patients, it's like a puzzle that we're trying to help fit together and find all the pieces. So moving on to the next part. So I do want to use some case vignettes to understand the next objective of how our multidisciplinary team works and confronts complex care issues. So the first one is a 5-year-old infant in the NICU who's referred to the DSD team for ambiguous genitalia. This consult probably gives some people heart palpitations. And one of the reasons is that just the social aspects of it make people very anxious. What do you say and how do you talk to the family? And this is not all like the nuances of how to work with patients or parents of a child with ambiguous genitalia, but these are some general guidelines. So remember that these parents are going to be unable to answer the very first question that people ask when they hear a new baby is born. So focus on what's positive and don't make it all about the genitalia. Remain gender neutral in your terminology, even maybe if the family isn't yet. And then right away, demonstrate that you have collaborative relationships, that you're working as a team, and emphasize this communication and actually really communicate. There's a lot going on and it should not be up to the family to fill you in on what other teams and other specialties are saying. In the first few days of life, there's typically a lot of unknowns and a lot of possibilities. Sometimes patients leave the hospital without a definitive diagnosis or even a definitive sex of rearing, assuming this is a conversation that needs to happen. Because there are so many unknowns, immediate access to a multidisciplinary care team is crucial for the health outcomes for both the patient and for the parent. I am focusing on the GYN aspects of care in this lecture, but this is a broad overview of the function of different team members for patients such as this one, which you can see can overlap, but that's not the same as being redundant because each specialty brings their own unique expertise to the situation. The NICU, the neonatology team, is managing the overall infant status, and making sure there's no other health concerns, consulting appropriate specialties, and ordering diagnostic testing. Endocrine is following and helping to order and manage the initial metabolic testing, as ambiguous genitalia most often is due to salt wasting congenital adrenal hyperplasia. Genetics is initiating testing and providing genetic counseling, as well as looking for signs of any larger syndromic conditions. Psychiatry is already initiating therapy, obviously not for the baby, but for the family. The family is processing a trauma, and often they're feeling at a loss as to how to even talk about their baby to their friends or their family. They're also helping the family to process the sex of rearing conversations, again, if those need to happen. And then urology and gynecology are helping to assess the anatomy of the reproductive tracts and also assisting in ordering and interpreting diagnostic testing. So more specifically for gynecology in the NICU, after introducing myself to the families as part of the DSD team, I'll usually check and see what their understanding is of the reproductive anatomy. Often everyone is focused on potentially more life-threatening needs, and the GYN aspect may or may not have been discussed. Sometimes there are immediate surgical needs, and for sure, we try to get as much information about reproductive anatomy as soon as possible when we're in this time period where maternal hormone stimulation is at its peak, and you can really see the uterus and the ovaries. After the first few months, the uterus and the ovaries are often so small that you won't see them again until puberty. I also fill the families in on the parts of care, not just of what I'll be helping to manage in the NICU, but what we'll be following as outpatients. And this last part here, I cannot emphasize enough. We're very unlikely to have any answers to any of these questions in the NICU, but I still bring up that GYN will be following along to help assess the child's future puberty development, future sexual health, and future fertility needs. Because future questions are what's already on the family's mind, and they're so hesitant to bring them up in the setting of all the other pressing health concerns. I was in a situation once where I was doing a combined vaginoscopy with a colorectal team for a child with imperforate anus. And I came out and told the family that the vaginoscopy was normal. And the family broke down crying and told me that that was the thing that had them most worried that day. And I told them we better not tell the colorectal team, who is in the OR starting their 3 or 4 hour surgery. But the ability to love and be loved intimately is so important. And it's really cool to me that gynecology gets to help address those conversations. Unless a prenatal diagnosis has been made, often all that's known is that at birth, the genitalia might look something like this. An exam of the genitalia is really important. So measurements of the clitoral length and width are helpful to determine if there's clitoromegaly present. Noting what openings are present and where they are. So in this first picture, there's a urethral opening at the tip of the phallus, but often there's a single opening at the base of the phallus, and usually this turns out to be a persistent urogenital sinus that opens into a urethra and a vagina. Noting openings also includes noting the location of the anus and making sure it's in a normal position. Looking at the labioscrotal folds, so this third picture, you can really see that there's often like scrotal-like hyperpigmentation, rugae, and then posterior fusion. And then examining for gonads and trying to determine where they are. Do you feel gonads in the labioscrotal folds? Can you feel them in the inguinal regions? And if not, are they apparent on your abdominal imaging? So the workup usually initially involves close electrolyte and glucose monitoring, although salt wasting usually doesn't start until around day 4. And then looking at a hormone profile. So again, AMH at birth is usually much higher for boys, and this would be considered in the female range. And then this patient ended up having congenital adrenal hyperplasia. So you can see this very elevated 17-OH progesterone. Newborn screen and genetic testing later confirmed it, and the karyotype was 46XX. The imaging showed normal reproductive and urologic structures, except for the persistent urogenital sinus. So in the 2006 classification system, this would fall under 46XX DSD, disorder of androgen excess. So again, everyone's role in the NICU varies. This is what things might look like for a patient with CAH. And now I kind of want to transition to this outpatient care of a patient with CAH, which again involves members of the team, but this is where for gynecology and for urology, things can start to get a little bit more complicated. So outpatient care for CAH, definitely we talk about pubertal expectations and monitoring, often along with endocrine. With REI, we're talking about fertility expectations. And then with urology, we're talking about surgical decision making. And this is one of the major controversies of this field. So traditionally, genital surgery for ambiguous genitalia was included an automatic genitaloplasty at birth. Currently, there's a shared decision-making process between the medical team, the parents, and is more and more trying to include the patient in these conversations. There are so many factors to consider when talking about genital surgery for ambiguous genitalia, and we're going to go through just some of them here. So just a broad overview of what this surgery looks like. So there's two main portions. One is to address the urogenital sinus and separate them into the urethral and vaginal tracts. And two is to feminize the external genitalia by reducing the clitoral size, creating a labia minora, and separating the labia majora. A lot of things have to be kept in mind just from a surgical planning standpoint alone. So definitely looking at whether or not there's actual medical indications. At a young age, this is typically urologic indications. Is there obstruction? Are there urinary tract infections? Are there voiding dysfunction? Oftentimes, though, that these are normal and there might not be a true medical need for immediate surgery. The patient's anatomy dictates what kind of surgery. So in this diagram below, you can see a urogenital sinus can have this confluence of the urethra and vaginal tracts very near the introital opening, or the vulvar opening, or it can be up much higher, and that actually adds a degree of complexity to the surgery and also a little bit plays a role in the timing. And then overall, this timing question, so in infancy, there are some obvious advantages. The patient doesn't remember anything. The surgery is kind of completed and behind them, but it totally disregards autonomy. And there is, we'll get to a little bit of a frequent need for revisional surgery. But then there's other ramifications for waiting later, and a lot of these are really unknown. Never is not really an option for most patients who want to engage in future vaginal intercourse. Our urogenital sinus is typically too small, and because the urethra is right there, you can't really dilate it appropriately. And it's also not advisable to have sex in a urogenital sinus due to infection risk. One of the things to really understand is that long-term outcomes for these surgeries as performed in the past were initially not good. So 1966 was the first publication of a surgical technique to reduce phallic size, and it involved excising the clitoris. Data from 2001, which keep in mind is now 20 years ago, found that almost everyone needed some sort of intervention for the vagina, and most of these required a second surgery. So it's really important to understand the political and social climate to know how recently in our history this was, that these patients who experience these really horrible sexual health outcomes are alive and are not even that old. And it's also important that because of the changes in technique over time, that we know that long-term data on current modern techniques is really lacking. So short-term complication rates for things such as dehiscence, urinary dysfunction, infections are pretty well known. The long-term rates, looking at sexual health outcomes and cosmetic satisfaction of the patient for their own genitalia are really lacking. More modern techniques were really first initiated in the 1970s, and then there was a pretty steep learning curve in the 1980s. And again, even newer techniques introduced again in 1990s, and still more being developed. So this is a 2020 paper attempted to put together complication rates for genital reconstruction using modern techniques. And almost all of their patients, 91% of them, had CAH. This is from 12 centers, and they had 57 patients. 50 of them had surgery, 18% had some sort of post-op complication, and most of those required re-intervention. They reported only a rate of 8% who had vaginal stenosis, but keep in mind that they were only following these patients for 12 months. They noted 7 patients in their series who had no surgery, and that these overall were rated by the parents to have started with baseline better cosmesis ratings. So looking at patients who've had no surgery, we do not have good data on long-term sexual, psychosocial, or urologic outcomes for patients who choose not to have a surgery. What little data is out there is not very promising for good outcomes, although it mainly comes from developing countries where patients were unable to access care and so had a very late diagnosis. And the social climate for GSD conditions there might not be comparable to ours. Or then again, maybe it is. I have in mind a 4-year-old patient who was being raised as a female who I saw in the clinic, who had an erection of her clitoral tissue while running around at the pool in a swimsuit. And she was really traumatized by the reaction of the other kids. To my knowledge, there's only one study of patient opinions about their own feminizing surgery. And this actually, most of the patients felt the timing of their surgery was correctly done, and the median age of surgery for those was at 2 years. So with those surgical considerations in mind, we have to focus on the ethical considerations. So beneficence is to do good, non-maleficence is to do no harm, autonomy is that the patient makes decisions for themselves. Open future is the child having as many, having rights to as many future autonomous decisions as possible. And best interest is the balancing of the welfare of the child, the family's needs, and the treatment efficacy. So of these, you can see that autonomy has really taken a backseat in the past to the detriment of many of those patients who experienced poor outcomes. And it's now much more appropriately taking a front seat, but this is where it gets even more complicated. So in 2017, Human Rights Watch and Interact, which is a patient advocacy group for patients who identify as intersex, which is many of them have CAH, they issued a written statement urging a moratorium on all surgical procedures that seek to alter the gonads, genitals, or internal sex organs of children with atypical sex characteristics who are too young to participate in the decision, unless delaying the procedure carries a meaningful risk of harm. Both right around the time before and after that statement, many human rights, social, and political organizations have joined in this statement, and pressure has been placed on physicians and hospitals to cease the practice of genital surgery. This headline is from July 29th, 2020. This is talking about Lurie Children's Hospital in Chicago, which is a major DSD center. Leading up to this headline, Lurie was subject to a negative social media campaign and on-campus protests. And really, it very much makes sense. The problem is on us, right? The problem is on society. The child, if the child doesn't have a urologic problem with no UTIs, obstruction, retention, or pain, then who are we doing the surgeries for? And this has led to political pressure as well. So this is SB 201 was voted on in January 2020, the last of our days of normalcy. This would have limited surgery in people born with variations in their physical sex characteristics if they were less than 6 years old, unless medically necessary. Medically necessary would be defined by a board that was to be appointed by the Medical Board of California. This was voted down, but there's been similar bills put up for vote in the past, and there certainly will be more in the future. So some of the vague wording of these bills is problematic. So what's medically necessary, and who are the people on this board that will be deciding that? A really common consult for us in pediatric gynecology is for labiaplasty, for labia minora hypertrophy, which is commonly perceived to be a cosmetic surgery. But I had a patient in my fellowship with a 16-centimeter labia minora with development of skin ulcerations. Are you going to tell me and that patient that that's medically unnecessary? And for me personally, I come from a state, I grew up in Ohio, where politicians have a lot to say about what is medically necessary between a pregnant woman and her physician. So I'm extremely wary of state intervention in reproductive health. In particular, The focus of surgeries of these bills in some states can sometimes be very focused on genitoplasty for females and less focused on other similar conditions such as hypospadias for males. And I'm wary of any hint of directing control of women's bodies. So as a DSD group, we're constantly discussing this and how to navigate this process with the political and social landmines involved. And we're staying very involved in this very public, but also very private discussion. We were involved, our urologist led up an initiative through our group that argued against the passage of this bill. And we've already reached out and have started meeting with patient advocacy groups, and it's been really cool to hear the patient perspectives. Medical organizations are mainly in support of maintaining an option for surgery, although not unilaterally. NASPAG, which is our Pediatric and Adolescent Gynecology Association, released a position statement endorsed by the Pediatric Endocrine Society that's actually pretty brilliantly worded. It manages to convey that they're neither for or against surgery, but that they feel that this is an individual decision and surgery remains an option. And this mindset of surgery being an option is supported by one of the largest patient and family advocacy groups for CAH, which is the CARES Foundation. So the problem becomes very complex when you have this infant and their family in front of you. You're trying to help this family make a decision that's extremely complicated and fraught with emotion that affects their child's future in significant ways. And you're trying to almost predict what this child would want in the future. Families, more than you might expect, or maybe more than I expected, are extremely expansive and open to non-binary gender and sex possibilities when given the proper support. But in a very real sense, to not do surgery is to ask this family to put their child at the center of a social and political experiment. Conceptually, yes, it's not the child's problem that our society can't deal with the non-binary. Practically, parents are saying, I don't want my kid to be the one who has to fight that battle. I'm going to pause for a second. And Paula, are there any questions that it looks like maybe there's some?
So if I can just step in here, and it's a variant of the one question in the chat. You talked about your scenario was a 5-hour-old infant, and
Yeah.
I'm going to ask you to step back even further to the general OBGYN or family physician who's delivering the baby.
Yeah.
So this is the classic question. What if I deliver a baby with ambiguous genitalia? And again, the first thing the parents ask at the delivery, mom's still feet up in the stirrups, asking about that baby. What do you suggest that the general OBGYN or the clinician who's doing the delivery would say?
So one, I think would, again, to try to provide some reassurance, because oftentimes you can still say like, hey, there's something going on here and we're going to figure this out. But look, your child is like, you know, a good color, is breathing okay, is moving around okay. And obviously we have a lot of work in front of us, but your child seems to be showing like every sign of health so far. And then indicating that you are not going to be working alone to figure this out, like, hey, we're going to be calling in the proper specialists and working together as a team to try to help make a diagnosis. Sometimes it's figured out, sometimes the genitalia are actually normal appearing, but it might not match now that more and more people are getting genetic testing done prenatally, especially NIPT, which gives them a karyotype. It might not match what was done previously. So sometimes in those situations, you don't have really any idea yet if there's a DSD happening or whether or not the genetic testing that was done previously was just incorrect or false. So I think in this situation where there's so many unknowns and absolutely this is a really tough situation, I would definitely just kind of offer already this idea of support and collaborative support. And frankly, I will say a lot of the times it's recognized by the neonatologist or the NICU team, and you know, not always by the delivering obstetrician, but obviously there's a lot of exceptions to that rule. So I don't have a perfect answer for you, but I hope that was a little bit helpful.
That's an honest answer. Thank you.
Thank you.
Stephanie, this is Dakeen. As
Yep.
to the meeting, I can't put a question in, but are any of these anomalies that you're speaking about, do they show up in ultrasound, prenatal ultrasounds at all? Like maybe if there's Müllerian defects that go along with them?
It can, and there can be some clues. So for example, renal anomalies are already a trigger to start to look for reproductive tract anomalies and vice versa. And sometimes even the lack of easily identifiable structures after about 14 weeks of gestation, easily identifiable external genitalia structures can be a clue that maybe there's something going on. Prenatally, again, you can already have a discordance between what you're seeing on ultrasound in terms of what the genitalia look like, male or female, and what has been shown on genetic testing such as NIPT to be the sex of the baby. So there's a lot of different ways that flags can come up prenatally, but a lot of answers cannot be known for sure prenatally. You don't know for sure exactly what the genitalia look like. You can't directly test the baby for hormones or anything like that yet. So even if you have a clue that something is going on, a lot of the workup will depend on postnatal care.
Stephanie, there's another question that is asking you to comment on circumcision and how it's similar and different from DSD surgeries.
So that's a really interesting and question that we could probably almost spend another entire session on. And frankly, I'm also, the urology team would have more expertise in this area, but you're right. Many people do include circumcision as being sort of in this group of genital surgery that doesn't have a really strong medical indication, although most urologists I know will argue that there are some sort of more minor medical benefits of circumcision. But without a really strong medical indication, it is considered kind of purely a cosmetic and almost a societal ritual. And again, it's interesting to me in all of these conversations about genital surgery, particularly these bills that are being passed, a lot of times circumcision sort of flies under the radar, which to me is like a little bit of an indication that maybe this is not all about genital surgery, but maybe this is more specifically sometimes about female genital surgery. All right, thank you. Good questions. I'm gonna move on. It doesn't look like there's any more for now. This second case is a 16-year-old female referred to GYN by her pediatrician for primary amenorrhea. So primary amenorrhea can go in a lot of different directions, and only some of them are DSD conditions. So you start with the basic workup. So this case was actually from Cincinnati Children's. On her history, we found that she had depression. She was using an SSRI. She was never sexually active, identifies as female, and had already experienced thelarchy and pubarchy, so the development of pubic hair, but not menarche. On exam, she had normal height and weight and BMI. She looked phenotypically female. Breasts were Tanner 3, genitalia were Tanner 4, with normal external genitalia. Later, as part of her additional workup, we ended up doing an EUA, which showed normal vagina with a single cervix at the apex. The speculum showed some hypoestrogenic changes to the vagina and a small cervix, but we were able to probe through it. Her hormone workup was consistent with gonadal failure, so very elevated FSH and LH, very low estradiol, low total testosterone, undetectable AMH and inhibin. Genetics showed 46XY karyotype with positive SRY on FISH, and imaging showed a large pelvic mass. So this is the pelvic mass on MRI. It was 14 centimeters. There were metastases to the pelvic and periaortic lymph nodes and metastases on CT of her chest to the lungs. An ultrasound-guided biopsy showed a dysgerminoma overlying a gonadoblastoma. She was treated with 2 cycles of neoadjuvant chemo with bleomycin, etoposide, and cisplatin, then interval surgery, and then 2 more cycles of BEP. Her surgery was an XLAP and a bilateral salpingo oophorectomy, which showed a normal but small uterus, normal bilateral fallopian tubes, a left streak gonad, and a right large ovarian mass. The path showed a gonadoblastoma on both sides, actually. On the right side also had overlying dysgerminoma, and also some ovarian-like stroma, although not clear ovarian tissue, and Leydig cells, which is consistent with testicular tissue. So if you're wondering what a streak gonad looks like, this is what it is. On the left side, we found this is the gonad itself. And then this is the fallopian tube here. And then this is what it looked like on the right side. So this is gonadoblastoma with a dysgerminoma. And you can see the fallopian tube there. And then intraoperatively, she has a little uterus right there. So this was another situation where there was multidisciplinary DST team management. So genetics did a workup which identified a pathogenic mutation in the SRY gene, essentially rendering it non-functional. And as you remember, SRY is essential for sexual differentiation. Psychiatry, so she at baseline had depression. This was becoming worse. And then helping this family and the patient with processing of this diagnosis on top of processing of her cancer treatment. Gynecology was involved in the surgical management, HRT, fertility. At Cincinnati, we were not as fortunate to have fertility team working with us, and then routine adolescent gyn care. Endocrine was crucial for the initial workup, and then also co-managing HRT. Social work also was really important for this patient and their family. And so this ended up being a 46XY DSD in this complete or partial gonadal dysgenesis picture, otherwise complete gonadal dysgenesis, otherwise known as Swyer syndrome. So I think this is also an example of how DSD patients just love to throw out and just like stomp all over the textbook. This patient had Tanner 3 breasts, which is a really rare Swyer syndrome variant, but has been reported by other DSD centers. So these gonadal tumors are something, a major topic of concern in another area of controversy in DSD. They arise from abnormal testicular tissue that's unable to fully differentiate. Gonadoblastoma and germ cell neoplasia in situ are the precursor lesions to overt germ cell cancers. These tumors, it's thought that gonadotropin stimulation may play a role in tumor development, which is consistent with most of these appearing after puberty. As a 2020 study in cancer epidemiology looked at over 1,000 patients who were at least 16 years old with DSD conditions, and they found that overall 12% of them had developed tumors, more in some subgroups, and especially high in, so the group of our patient that I just talked about with Swyer syndrome, it's up to 36% in those patients. These are some photos from a surgery that I did actually just last week. This is an 11-year-old girl with Turner syndrome. And I think it shows it's not such a straightforward surgery. So you have, here's a left streak gonad and left fallopian tube, and then the right streak gonad and right fallopian tube. And then somewhere in here is her uterus that has been totally unstimulated because of her total lack of functional gonadal tissue. And so delineating the boundaries of this streak gonad, which kind of, it's hard to tell, but kind of comes pretty close to where a uterus might be on both sides, is not always so easy. So because of this tumor risk, so that patient had a prophylactic gonadectomy, and this is something that's commonly recommended in DSD. The goal is to prevent germ cell tumors. And this discussion also has a lot of nuances. So this decision depends on the DSD diagnosis. So for example, this patient with gonadoblastoma, that the 16-year-old that we talked about, She falls into this category of someone who is estimated to have a 15 to 35% risk of malignancy. And she falls into this sort of high risk subgroup. But then there's other groups where the risks are thought to be less or are just unknown. And as we gain more data, different decisions might be made. So for example, in the case of patients with complete androgen insensitivity syndrome, there's been kind of a turnaround in the view of gonadectomies in these patients, which for a long time were routinely done before puberty. So these patients have a risk of developing a seminoma, and the risk is thought to be pretty low before puberty, but then after that, it's really unknown because most of them had already had a gonadectomy done. So we can't follow them. These are patients with a functional gonad. So this gonad is producing hormones, is going to help them get through puberty, provides support for bone health, and removal would make this patient dependent on HRT. So newer analyses show that maybe this precursor lesion risk is 10 to 15%, but the progression to cancer is probably pretty low. There's, in 2018, an overview of 166 women with CAIS. Only 24 of these women still had their gonads, but they ranged in age from 16 to 48 years old, and none of them had a known seminoma or a known precursor lesion. Gonadectomy rates vary widely by center, and in this study that was shown that some of the centers were reporting 0% and some were reporting 100% of their patients with CAIS had the prophylactic gonadectomy. So because of some of this data, a lot of people are pushing back and saying that maybe for these patients who have some benefit to retaining the gonad, that we should not be doing prophylactic gonadectomy, or at least potentially waiting until they're older to make their decision for themselves, and given the low tumor risk. The location of the gonad matters also. So the closer it is to the location of a normal testes, the less the tumor risk is. And somebody who has abdominal gonads with testicular tissue is thought to have a higher risk. It's actually, the ability to monitor gonads is also depends on the location of the gonad. Tumor markers are not helpful unless an overt malignancy is developed, and even then are sometimes negative. Palpable gonads might be in the labioscrotal folds or in the inguinal region, and sometimes there you can use palpation to help to monitor for changes in the gonad size over time. Imaging with ultrasound or MRI has shown not only to be not reliable for tumor surveillance, but it's also not even reliable to help you identify where the gonads are, which can be a challenge. If they're not in the labioscrotal folds and they're not in the inguinum, then hopefully they show up somewhere on your abdominal imaging, but sometimes they don't, and that does not mean that they're not there. So the age of the patient we touched on a little bit already, and this already gets into bioethical considerations for patient autonomy. Fertility potential, I think this is where Stanford really has a unique resource of having our REI team be a member of our DST team. We joke in DST that fertility is asked about by the patient and their family at almost every visit. And there's so much going on in the field of fertility preservation right now. And almost no centers have that have multidisciplinary DST teams have REI as a consistent member of that team. So I thought this was an interesting study. This was out of Northwestern, 44 patients with DST conditions who underwent gonadal biopsies or gonadectomies. They were looking for germ cells and found that 68% of these patients had germ cells present. And what was really interesting to me, that this was even in patients with streak gonads, which we typically think of as being totally non-functional, or ovotestes. Now there are like a million steps between these numbers and a live birth, including we don't have information on the gonadocyte quality or its ability to mature. We don't have good information on, or we don't have good maturation techniques for this kind of tissue. Condition-specific presence of gonadocytes is unknown, and many, many more questions there. But it is interesting data, and particularly some of these questions that the authors bring up, because they looked at over time with the age of the patient, how the number of germ cells changes over time. For patients with normal ovaries or patients with ovaries who have a DST condition, the germ cell count decreased over time, but that's also kind of an expected finding for ovaries. For patients with testicular tissue, without DSD, that count should rise, but in fact, for DSD conditions, fell pretty steeply. So the authors are wondering if delaying the gonadectomy, which is of course the push that is happening in the field to try to gain more patient autonomy, if by doing that we might actually decrease fertility potential. And they're wondering if there's a role for gonadal tissue cryopreservation, which in fact is something that this same group ended up exploring 2 years later. They published a paper, and this was a much smaller series, so only 10 patients with DSD conditions undergoing gonadectomy were offered gonadal tissue cryopreservation, and 5 of those patients had germ cells present. One of them opted not to cryopreserve because they identified as female, but only spermatogonia were found. One froze both oocytes and spermatogonia. So it's really interesting what's happening with these patients. So the hormone potential also plays a huge role in the decision whether there's functional gonadal tissue and whether this aligns with gender identity. This was a paper out of Seattle Children's that looked at 3 patients with 46XY DSD with female gender identity. And the way they were trying to get around the issue of these patients having some testicular tissue that was thought to put them at risk for androgenization was to essentially suppress their puberty with GnRH agonists, and then which allows them time to develop their own gender identity and potentially even get them to the point where they might decide on their own to have a gonadectomy at age 18. There's a lot of different approaches to this. Families using culture also play a role, but you can see how just in this one decision, already a multidisciplinary team is crucial to decision making. All right, I'm gonna stop also here for questions, and then I'll go through the last part is quick, just about our resources here.
So there is a question from Barry Bear stating that the Stanford group is going to improve techniques for in vitro maturation, and the question about what is being discussed with patients in the hope of future developments.
So right now we are not offering gonadal tissue cryopreservation for patients who are not thought to have any functional gonadal tissue, although this is actually something that myself and the REI team that works in the DSD clinic have been talking about, and some centers have started these experimental protocols that we're looking into for the future. So Barry, I think probably you and I and the rest of the REI team will be involved in some of these discussions in the future.
That's all the questions I see.
Okay, perfect. So as you know, we have myself and Paula on the gynecology team here. We now also have the addition of Nicole Tyson, who is joining us in October. So our clinic, so I think Paula gave me a little more credit than was due for my role in the initiation of this clinic. It was actually initiated in June 2018 with just the endocrinology and urology teams, and now is a full cohort of specialties and subspecialties. And some of these are pretty unique. You know, again, having such a strong gynecology and REI presence, having a strong neonatal team, these are not common to a lot of multidisciplinary clinics. The referral pathways, so prenatal diagnosis is becoming increasingly common. NICU consults are still one of the pathways that we get referrals. And then of course, outpatient referrals probably are still the mainstay of our referrals. And I just want to highlight this, direct to consumer genetic testing is also a newer thing in our field that's creating earlier and sometimes unexpected diagnoses. And in fact, that patient, that 16-year-old who had the gonadoblastoma that we talked about earlier, she was referred to gynecology because she had ordered a 23andMe test kit, which resulted in XY, which then prompted immediate workup of her pediatrician of her primary amenorrhea. And this is actually, we published a case report in Pediatrics about this. So we have another multidisciplinary program here that's really amazing that addresses complex fetal anomalies. there is overlap of some of the providers in that multidisciplinary group with our DSD group, which makes it really nice. If a patient is thought to have a DSD condition prenatally, we can try to direct those same providers so that they have continuity of care prenatally and postnatally. And I think this is critical for all the specialties, but probably most for the psychiatric specialty, who is already talking to the family beforehand about things like fetal bonding when you can't picture what the baby might look like, or what to name the baby, or how to talk to your relatives and friends. We offer DSD team prenatal family meetings to everyone, although many families don't take us up on that prenatally. They're already pretty overwhelmed with the number of providers, and there's a lot of unknowns that we can't answer yet. There is an outpatient EPIC consult. If you search for DSD, it comes up with our ambulatory referral. There's also an inpatient consult. If you search for DSD on SmartPage, there's a way to actually page our team. And then we're part of the Translational Research Network, which is a nationwide network of DSD patients. And in doing so we're involved in research activities with them. We have standardized history and consent forms that we use for all of our patients to try to standardize data collection. And we do case presentations 1 to 2 times a month, and Stanford just presented our first case to the DSD team. So this is just a summary of research involvement that's going on and future possible research directions. So psychiatry is working on a standardized intervention for DSD families with the goal to have about 6 sessions to offer to newly diagnosed families to help process the events. Health disparities projects are going on in the DSD TRN. And then there's nationwide recruitment open for within the research network for multiple different DSD conditions. In the future, as you might guess from just the controversies in the field, so gonadectomy outcomes, gonadal tissue cryopreservation, genital surgery for sexual health, and particularly long-term psychosocial and sexual health outcomes for patients who both choose or don't choose to have surgery is our future directions that we might take here. So I thank you for listening to this. I'm junior faculty, but I have just enough experience with these patients to know that in 50 years, I could not still feel like an expert in this field. But if there's any additional questions, I'm happy to take them right now.
Thank you, Stephanie. That was really a wonderful presentation, and you are perfectly on time. You have about 1 minute and 1 question. So that's the last one. The last questioner talks about brain maturity and how that doesn't, we know now that that doesn't really happen until people are in their 20s or even 30s. And the questioner asks about regret. And so comments about the studies that have looked at regret among individuals who made their decisions even later on, not the decisions that were made by parents, but the decisions that they may have made as a teenager.
Yeah, it's an interesting question. And it's interesting, especially when you think about like with this data about brain maturity, you know, we still use 18 as the age of majority and the age of someone being able to consent for themselves. When patients are younger, so in the 12 to 17-year-old age range, there's something called assent, where the patient is not the one actually providing the consent, but it's considered ethically sort of irresponsible to continue with a procedure or a treatment if the patient, who at that point is kind of aware of what's going on, does not give their agreement to the process. And of course, at that age, like, you know, we're talking about like a 12-year-old sort of agreeing to be a part of the process. Obviously, the decision is still really coming from the caregivers and the providers, and how they're presenting this to the patient too. In terms of patient regrets, there's unfortunately really, really lacking data. So obviously there's a lot of anecdotal accounts, and a lot of that is what stimulates some of the discussions going on both socially and politically. And some of them are about patient outcomes with unsatisfaction with their outcomes. But in terms of looking at whether or not the patients would choose to do things differently, there's really no data that I'm aware of coming from decisions that they were involved in. There's just the one study that I know of that looks at the patient's opinion on the decisions that their parents made. So that is definitely an area that we need more research.
Great. Thank you so much. And I think we will end right on time. Excellent talk. Really appreciate it. Thank you.
Thank you, Paula. Thank you all for listening.
Thank you, and we'll see you next Monday. We'll send out the announcement for our grand rounds on the 21st. Thanks, everyone.